So, Assalamu alaikum everyone. This is Dr. Mariam Hassan from Shaukat Memorial Cancer Hospital. I welcome you all to this webinar on ethical challenges in cancer care during COVID-19. This is a part of a series of educational webinars. Okay. Assalamu alaikum everyone. I'm Dr. Mariam Hassan from Shaukat Memorial Cancer Hospital. I welcome you all to this webinar on ethical challenges in cancer care during COVID-19. This webinar is part of a series of webinars that our hospital has been organizing on various aspects of cancer care during COVID-19. So our plan today is to cover the ethical challenges that healthcare professionals have experienced in Pakistan while providing cancer care during the last few months that we have been dealing with this epidemic. So there has been a lot of discussion lately in scientific communities about the issue of subverting global health while dealing with COVID-19. So COVID-19 has resulted in a state of global panic and fear. And while most of the resources have been redirected to cover for this pandemic that has affected the whole world, it is feared that other diseases that have huge mortality and mortality across the globe, including other infectious diseases and non-communicable diseases like cancer, have suffered badly as a result of this. In global health, context and social justice and equity matters a lot. And these are going to be some of the points that we will be covering in our discussion today. So what we will do is that we'll start off with Professor Amir Jafri from Center of Biomedical Ethics and Culture at SIUT Karachi. He will present to us the guidelines for ethical healthcare decision making in Pakistan during COVID-19. The Center of Biomedical Ethics and Culture has come up with these guidelines after a lot of expert consensus, and these guidelines have now been vetted by the government of Pakistan as well. So these are what we may call our national guidelines on this matter at the moment. We will then move on to Dr. Halima Saeed. She is a pediatric specialist and she works at Shaukat Khanam with children who have cancer. She is going to be discussing resource allocation and prioritization for pediatric cancer care during COVID-19. And then she'll be followed by Dr. Ume Kulsoom, who's an adult clinical oncologist. She will share her experience of cancer care during COVID-19 and the prioritization decisions that have been made for adult patients with cancer. They will be followed by Professor Athar Mukhtar Siddiqui, who is an anesthesiologist and an intensive care specialist at Shaukat Khanam, and he will be sharing with us the challenges experienced during provision of critical care services during this pandemic. We'll end with Professor Bushra Shirazi. She's a breast cancer surgeon at SIUT Karachi, and she will share with us the dilemmas faced by a cancer surgeon during provision of cancer care, more especially surgical services to breast cancer patients during these last few months at her center. We'll end with a panel discussion where we will take question and answers from our attendees as well. So without further delay, I think we'll start off with Dr. Amir Jafri and his presentation. So we need to stop sharing. Okay, so Dr. Amir, over to you, and if you could share your presentation and you can start.
Great, Assalamu alaikum, and I'm glad that I've been invited for this very important webinar. Can you see my slides? And can you hear me? And can you see me? Can you see the slides?
Yes, yes, please.
Okay, I'll just focus because I'm. So this is a kind of a new system for us, um, which we are trying to figure out how to use. Let me just zoom in into me, and then we can start off. So I'm delighted to be invited to this very important panel.
Full screen
Full screen करा दिया? Can you see me? Can you see the full screen? I think they can hear me. So can I? So am I live? Am I on?
Yes, sir.
Okay. So I'm very happy that from the platform of the Center of Biomedical Ethics and Culture at SIUT, we've been invited to share our experience in contributing towards these guidelines. These guidelines are the COVID-19 pandemic guidelines for ethical healthcare decision making in Pakistan. So the rationale, and as Mariam alluded to a little bit earlier also, we've been involved in these, the center has been involved in these developments. The rationale was that we were getting, there was an anticipation way back in March, and March seems like a long time ago, although it's just 3 months back. But we were anticipating a major crunch on our health facilities for the allocation of whatever scarce resources that we have for the care of patients, including COVID patients. But the anticipated increase of COVID patients was going to overwhelm our medical facilities, and this was predicted based on other models across the world that were experiencing this at that time. So we started preparing for that, and one way of preparing for that was to develop these guidelines. We were receiving queries from our colleagues about what to do when this kind of a thing happens. This was coming up from our students, from our colleagues, etc., as to what was happening, which is why we then started to put together these guidelines. By brainstorming, we made a committee within CBEC, and then through that we developed a framework, and we sent that framework out to other public and private sector key informants, who gave their input also, so that these guidelines developed into a major draft. This was then sent to the National Bioethics Committee of Pakistan, which works at the federal level, and this was ratified by the NBC, and then it was sent for endorsement by the committee to the Special Assistant to the Prime Minister on Health, and with his input to the expert committee of the NCOC, the high part committee that is looking after the COVID matters. So all of these processes took place to the point now that this has been ratified and owned up by the government as the national guideline for this particular purpose, and this is now included in the covid.gov.pk website, which contains all the various guidelines that have been created. So this was a little bit of a rationale and the process. So because I have very little time, so I'll just rapidly go through some of the major features. So aim of the guidelines was, as I said before, we were anticipating a crunch on our facilities because of rapidly increasing COVID patients on ICUs, on ventilators. Not only that, also on ward beds and on tests and on medications. Plus, we were also anticipating that the vaccines, whenever they come, will also have the similar issue of larger needs and fewer resources. So how do you operationalize that into reality on the ground? So that was the basic aim of these guidelines. So they are broad-based guidelines from that point of view. Our approach was that, as has been the approach for the various other guidelines that have come across on these terms throughout the world, that they're focusing on the greater benefit for the greater numbers of people rather than on individual patients. Now, the focus for a clinician is on individual patient, but when the public health crisis of this nature comes in, our focus automatically broadens to look at the larger good for the larger numbers. So, which is how these guidelines have been formulated, and similar guidelines across the world have also been formulated on the same principle. So while looking at the COVID patients, one of the major stresses of these guidelines is looking at non-COVID patients and to see that the same rights, they have the same rights as COVID patients, So the COVID patients, although much more increasing in number and much more of an acute emergency, should not in any way decrease resources for non-COVID patients. But how do you balance that? So I think our discussion today later on also will be based on the non-COVID patients as well. So we'll take it over there also. So our decision-making criteria that we discussed for these guidelines has three major criteria: age, probability of survival, and expected outcomes. Now, these are based on medical facts rather than on numbers, etc. So there is no cutoff that our guidelines say that this is the age group under which all resources must be provided, and above which you may not provide resources. So we don't have a good cutoff. We don't have a single cutoff. We say that it has to be looked at. Age has to be one of the factors, but it has to be considered in the context of the entire medical spectrum of that particular patient. So it has to be looked at in the context. Then the probability of survival, another medical thing. So the comorbidities that the particular patient will obviously impact on the survivability potential of that patient, and they must be taken into account while giving them scarce resources like ICUs or ventilators, beds, etc. Then the third thing was the expected outcome. So again, this is a medical criteria which determines the functionality and the functional status of that individual upon the possible survival from the ICU stay, etc. So all of these things have to be taken into account while allocating scarce resources to patients. So while allocating resources, we also have to set limits to free up ventilators for those who can be saved from those who cannot. So a do not resuscitate order must be very clearly formulated for those who are not improving, and this must be documented. They should also be in dire circumstances, in extremes of situations, even the possibility of withdrawal of support where the support is actually deemed to be not medically feasible and that it is not actually helping the patient survive and is only prolonging death. So there's some framework in which the patient, the life support from the patient may be actually withdrawn. In such cases, patients should not be abandoned or should not feel abandoned. They should not feel abandoned, but they should be provided compassionate care, supportive care as we progress. So these patients who are not provided because of medical grounds intensive care should then be cared for in some other appropriate place where they are cared for, given oxygen, etc., and cared for compassionately. So they're not being abandoned. All of these things of setting limits, of withdrawing, or whatever it is happening should be communicated very thoroughly and honestly and directly with patients whenever possible, and also their surrogates from the beginning, from the time of admission and through the hospital stay. One of the things that we've seen over the past 3-4 months is a break of communication leads to misgivings, leads to miscommunication, leads to the kind of reaction that we've seen in the public many times. So the communication has to be robust from the time of admission onwards, and this communication channel has to be established right from the very first go. ICU admission criteria and the possibility of the DNR and the possibility of withdrawing of support must also be made known to the patient and or their surrogates at the time of admission, that there are very clear criteria that we may actually have to withdraw the support. The third thing was that these standard operating procedures should not just be filed away somewhere, they should be known to healthcare professionals so that they know how to act, and also to the public. So it should be transparent. The transparency is extremely important. Again, one of the things that we've seen because of the various media reports, etc., we've been having the negative reports, is because of a lack of communication or a lack of perceived transparency. So that is very important to be established right from the very word go. These guidelines have stressed on that. The process of decision making must involve colleagues, peers, administrators, and must be documented so that it is very clearly, the reasons are clearly known. If there is a hospital ethics committee, its involvement obviously would be there. But if there is no hospital ethics committee, then at least 2 physicians or more should be involved in the decision making so that the moral burden as well as the emotional burden on an individual is lessened. That's a very important thing. The decisions that are made must be made swiftly so that others may be saved. So procrastinating on a decision is, yes, we will do a DNR policy on this, apply for DNR policy on this, or withdraw support or whatever, not escalate. All of these things, if this is decided, then it should be acted upon so that precious time and resources may be saved and other lives may actually be saved. So one very important aspect of our guidelines, which is sometimes which is available and reflected in other guidelines from across the world also, but very forcefully in our ones, is that frontline staff, which includes doctors, nurses, ancillary staff, cleaning staff, security, and others in the front line must get priority. They must be guaranteed in their institutions a priority for appropriate gear, appropriate PPEs, and also if they get infected, they must get priority for care within their institutions. And not only that, this is based on the principle of reciprocity, and also the principle, very important, of utility, that these people are the people who will get well and then come back to work and save other lives. So it is very important, it's pragmatic, and also it is also reciprocal, it induces reciprocity, that yes, the community, the society, and the hospital owes it to these individuals who are risking their lives every single day for saving others. Another thing that our guidelines indicate, which have actually not been indicated by any other guidelines that we've reviewed, is that the same prioritization should be given to first degree relatives of first line professionals. And this is an important part because among our various deliberations, this was stressed again and again, because we believe that our frontline workers, our hospital staff, our people who are working at the forefronts are only able to do so because their families support them, and they work with fear that they may actually bring the virus home to their elderly parents or whoever it is at home. In case this happens and they become the source of infection for their elderly parents or whoever is at home, though they should be guaranteed that yes, their relatives, the first degree relatives, will also get priority. This is something that has actually not been dealt with in any other guidelines, but we have stressed this in our guidelines, and it has been endorsed again, as I said, by the government. Another very important thing is indemnity for HCPs. The healthcare professionals are making very, very difficult decisions in very short periods of time, given whatever resources that they have. Their action must not be paralyzed because of fear of reprisal from the government, from litigation, or from angry relatives. So they must be given protection not only from angry relatives, but also from legal action against them for these particular decisions that they have made. These decisions, of course, have to be, as we have said before, they have to be done collectively. But once they've been done collectively, it is owned by the institution and is not on the onus of just one individual who's making this decision. So this kind of indemnity is important. And again, as these have been endorsed by the government, they have endorsed this point as well, that this reciprocity has to be there. So this is another thing that many other guidelines do not have. We have stressed this upon ourselves, and there are various ways of operationalizing them, which is another matter to discuss later. But so these guidelines differ from others in the action as far as reciprocity to the healthcare workers is concerned, security, indemnity for the healthcare workers and their decision is concerned, and also prioritizing the healthcare workers' first degree relatives in case they get infected. So the guidelines are available now on the covid.gov.pk website among the various other guidelines, and they can be accessed on this URL. They're also available on the National Bioethics Committee website, also on the CBEC website, and also on the National Institute of Health and IH Pakistan website. So I thank you very much, and I hope that this can be followed later on by a discussion. I'll be happy to answer questions. Am I there? Yeah, okay.
Okay, thank you, Dr. Amir, for this very comprehensive review of these guidelines. So we have several burning questions for you, but I think we'll just move on with the next presentation for now, and we'll reserve all questions for the Q&A and panel discussion at the end. So Dr. Halima is next. Dr. Halima, you are next. Thank you.
Assalamu alaikum, everyone. I'm Halima Saeed. I'm one of the pediatric oncologists working at Shaukat Khanum Hospital, Lahore. And I will be covering resource allocation and prioritization for pediatric cancer patients that we have had to face during this COVID-19 pandemic. To move this slide forward. So my talk will cover three aspects. Firstly, we will have an overview of childhood cancer. Then we'll talk a little bit about COVID-19 in children with cancer and what the experience has been. And then finally, the ethical challenges that we have all faced during resource allocation for these patients. So childhood cancer is a highly curable disease. People tend to think of it as a very rare thing, but approximately 300,000 children are diagnosed with cancer each year around the world. And in Pakistan, we see about 8,000 new cases per year. And this is a highly curable disease. So, when Dr. Amir Jafri was talking about looking at the prognosis and the outcome of a patient when you're prioritizing, so this population of patients has a very high risk of cure and long-term survival. This survival curve that you see on my slide here is, I think, a picture that no pediatric oncology presentation is complete without, which shows the enormous improvement in survival that we've seen from the 1970s, where most children with leukemia died, to the current time where up to 90% of these children will be long-term survivors, provided that they are treated according to protocol and the guidelines. Their outcomes of being long-term survivors are excellent. Now, when we look at COVID-19 in children with cancer, unfortunately, there isn't a lot of published data out there. There's a cross-sectional study from New York of 178 patients that were tested. These were pediatric oncology patients. Only 20 out of those were positive, and only 5% required hospitalization. There was no ICU, there were no deaths. So sort of showing that overall, the thought is that these are immunocompromised children. They might do worse than the rest of the population, but that has not been reported. Similarly, a French registry found only 33 patients out of that entire registry that had COVID-19 during the time that the pandemic was at a peak there. 5 of these required ICU care, and there were no deaths in this population. So the biggest informal data that we have that is unpublished is through the Pediatric Cancer Global COVID Registry, which is an international registry run by St. Jude's Global along with SIOP. So far, there have been 349 cases of COVID reported in the pediatric oncology population from 26 different countries. And what's interesting is that out of these, when we look at disease severity, only 9% required critical care, 7% had severe disease, and the vast majority were either asymptomatic or had very mild disease. So sort of that fear that we had initially that these patients might suffer from severe disease because of their chemotherapy and immunocompromised status has not shown to be true. Similarly, when they looked at the requirement for respiratory support, 76% of patients actually were okay on room air, and only 4% required intubation. So, obviously there are reports out there of kids that do badly. I'm not saying that everyone is going to do well, but there is no disproportionate increase in morbidity or mortality in pediatric oncology patients on active therapy that get COVID-19. So when we look at those two situations, we kind of have to look at the balance of what's more important. So we have childhood cancer, like I said, a highly curable disease, and definitely fatal if left untreated. On the other side, we have COVID-19 in children, where again, we have limited data, but initial reports do not report any increased concern for increased morbidity or complications in this population. So based on this, multiple organizations that deal with childhood cancer, like SIOP, Children's Oncology Group, St. Jude's Global, all got together and put out a consensus guideline, which was published in Pediatric Blood and Cancer. And essentially, it's a very detailed guideline that we have discussed in our Pediatric Oncology Forum before. But the summary is to give standard of care wherever possible. However, in spite of that, what we see is we are not able to provide standard of care. So just looking at our SKM experience during the first 2 months of the pandemic, so April, May, we had 261 patients that were on active therapy. And out of that, 103 patients were unable to get their chemotherapy on time. 9 surgeries were delayed out of the patients that required surgery during that time, and 3 had their radiation delayed. The delay in surgery and radiation was mostly due to hospital policy that anyone that tests positive for COVID-19 has to be delayed for about 2 weeks before they can undergo surgery. And also the OR was closed initially for a couple of weeks. All those patients had to be delayed. For chemotherapy, interestingly, obviously there are hospital-related delay factors, but for 89 patients out of these 103, the reason for delay was actually a non-availability of public transport. The families just could not bring the child to the hospital. So the ethical challenge in pediatric oncology is the need of the individual patient. Each one of these patients are going to be long-term survivors, have a good outcome if we treat them adequately. But on the other flip side, we have the justice and overall distribution of resources that we have, and obviously the risk to healthcare staff if these patients come into the hospital for chemotherapy or for surgery while they are COVID positive. So I'm just put together some of the ethical challenges that we have faced, and I would love some discussion in our session at the end. One of the problems obviously is limited inpatient beds for chemotherapy. The solution we have done so far is to prioritize all new leukemia patients and NHL patients who have a very rapidly progressive disease and would not make it if they did not start chemotherapy immediately. So those patients are prioritized, and after that everyone is on sort of like a list, and whoever is ahead on the list stays in their place and gets admitted as beds become available. But obviously the downside is that when you delay chemotherapy for these other patients, their long-term outcome is going to suffer. We know for a fact that even like a 5 to 6 day delay in chemotherapy can result in a reduction of about 10% in their overall survival in the long term. Then come those patients that test positive for COVID-19 and are asymptomatic. Now we have seen that it is safe to give chemotherapy to these patients, so we would be able to give it, but the problem is how to bring them into the hospital without putting the healthcare workers at risk. Initially, we were admitting them in COVID ward while we had room and we had staff to give chemotherapy there, but that is no longer an option. And so for most of these patients, chemotherapy is delayed till they are at least 2 weeks out and asymptomatic from their positive test to protect the chemotherapy staff and other patients and people in the hospital. But obviously, this leads to a delay in the chemotherapy for that individual patient, again leading to overall a long-term poorer outcome. And so here there is a risk of potential harm to the individual patient to protect other people, other patients, and the healthcare staff. Again, surgery of asymptomatic COVID patients has to be delayed to protect healthcare workers unless there's an emergency because of the high risk of transmitting infection to the OR staff and the surgeon, which, in trying to help this one patient, you could harm multiple patients if those personnel are infected. And one solution that we have for this is that we have very regular MDT discussions about these patients to prioritize once they're delayed and figure out how to get them the care that they need. Another population that causes a lot of ethical dilemmas is our palliative care patients. They deserve a good death. They deserve good quality of care at the end of their life. But when you're weighing the risks of giving a bed to a patient who is not going to make it versus a long waiting list of patients that could potentially get curative chemotherapy, sometimes you have to make the difficult decision to discharge these patients before they are ready, try to arrange the best possible home care for them, and again talk to the family about what the situation is and make sure that they don't feel abandoned. Social justice is a huge issue. Obviously, people with cars were able to make it to the hospital and get their chemo. Others could not. So that aspect is there, and autonomy is a big deal. So we've been trying to communicate as much as we can with the families, letting them know the situation. It's unfair to pretend that everything is okay with the therapy being delayed for their patients, because most parents will not buy that anyway. Again, because of COVID, because of limited outpatient clinics, a lot of times it's difficult to talk to patients directly. So we have established telemedicine clinics where we make sure we talk to the families and counsel them about what's going on. And a lot of times let them know what the standard of care would be, what they can get at our institution. And if they're able to go out there and get care somewhere else, they have that option. For example, one of my patients, when we were unable to provide surgery at Shaukat Khanam, went out and got it done at a private setup where they were willing to do it with the COVID-19 positivity. So, sort of at least you're informing the patients and letting them know what their options are. So in conclusion, childhood cancer is highly curable, and every effort has to be made to treat patients adequately. Obviously, the strain on healthcare services has led to an inability to provide that optimal care, and we really need to have multidisciplinary discussions and deal with each of these cases individually and prioritize based on their outcomes, like the guidelines say. So thank you very much for your time, and I look forward to an interesting discussion about these things at the end.
Assalamu alaikum. I'm Dr. Kulsum Aman, consultant medical oncologist at Shaukat Khanam Cancer Hospital, and today I'll tell you how we did our resource allocation for the prioritization of adult cancer patients during this COVID-19 pandemic. This is not working. So as we know that this is a global pandemic and this is affecting across the globe. This poses a unique set of challenges, not only for the patients, but for the healthcare professionals and for the healthcare systems. And we are trying to modify our treatment plans so that we can help our patients at their best, in addition to looking at our hospital resources. And as you know that during these times, not only we have to save our patients, but the hospital resources in terms of manpower is reduced, and staffing is also being affected. So we sat down and we laid down some guidelines and prioritized our patients into 3 different sets according to their requirement for treatment, and then all the adult cancer patients were treated like that. So priority A category are the patients who need the treatment there and then, and whether this is resource scarce, you have to treat them so that the patient can get the best prognosis. It includes medical oncology emergencies. For these patients, our emergency services are running 24/7, and before coming to the emergency, the patients are tested in a dedicated COVID camp. Then they are shifted to the emergency, where they are assessed by the physician in person, and whatever is required, whether it's admission, whether it's a surgery, whether it's a radiotherapy, that is contemplated for these patients. So the priority B patients are those who have no life-threatening condition, but we cannot delay their treatment by more than 4 to 6 weeks, because then we'll be hampering their outcome. These are the patients, the ones who need systemic care in terms of chemotherapy. We made protocols for all such patients as well. So this was the priority C category patients, where we took a sigh of relief, because these were the ones in which treatment plans or the services could be indefinitely deferred without adversely impacting their outcome. So what we decided was that these patients will be seen remotely via telemedicine clinic, or maybe in person after the things are better. So, but they will not have any adverse effect on their outcome, and these are the ones who have already completed their treatments, but they are on survivorship follow-ups and they do not have any outcome, any complication at the moment. So we know at Shaukat Khanum we are having MDTs, and every new patient is discussed in the MDT. Usually for early stage cancers, we do upfront surgeries, but because of the COVID situation, all the surgeries were initially stopped. And now we have our theaters which have started functioning again. But in all such patients, as per the MDT recommendation, neoadjuvant chemotherapy was given. Some patients, there were some patients in which even we started off with the hormonal therapy or maybe with the radiotherapy. Breast cancer, gynae oncology cancers are the ones where we started off with endocrine therapy when there was a complete lockdown and the patients, they were unable to come to us. We contacted them via telemedicine clinic. We gave them the prescriptions, texted them, sent them on WhatsApp, and some of the patients who could come over here, we gave the medication to them and told them how to use it. Now with all these things easing off, these patients, they are coming back to us, and if surgery is required, they are being sent back to the surgeons. Not every patient needs or could be treated with a hormonal therapy. Standard chemotherapy is required for most of the cancers, and we did start the chemotherapy for such patients. However, we did make some changes in the regimes, the ones which were dose-dense regimes, that is, the ones which were being given every 2 weeks. We spaced out to 3 weekly regimens. 3 weekly were being given on a 4 weekly schedule. We used filgrastim, the colony stimulating factor, very liberally, and we prescribed our patients anti-emetic routinely so that they do not have to come to the hospital and the risk, exposure risk is reduced. Talking about the targeted agents, many of the cancers in adult oncology, they require targeted agents, and one of such agents is trastuzumab. We switched it to the subcutaneous route so that they come to the hospital, but their stay is not that prolonged and the risk is reduced. Some other agents like pertuzumab, they are the ones which are being given through IV route. Immunotherapy and TKIs are also still being given, but the oral ones are given, are dispensed to the patients for 2 months instead of 1 month. And our doctors, including the consultants, residents, and the fellows, they contact the patient on telephone or via video call, and they are following up their side effects. For advanced cancer, metastatic disease, we looked into the patients population, all those patients who had a metastatic disease, all those who were diagnosed with stage 4 cancer, but they had not started off their treatment when this pandemic happened back in March. We asked them to stay home depending on their condition. We did not start off with their chemotherapy or treatment at that time, and now they are coming back to us because there is no traffic or any other problem. We staged them again, got their CT scans done, and now we have started them on their chemotherapy. Those who require targeted agents, we are giving the targeted agents, but we again spaced out their dosing interval. CDK4 inhibitors are no exception. They are also being given in many cancers. We thought of increasing the schedules, but our patient number is not that high, and those reductions or spacing out the regime time has not been done so far. However, few other patients who require the supportive care in the form of endocrine treatments or LHRH agonists, we have done some changes in that as well. The ones which were being given every month, now we have changed to 3 monthly regime, and the patients who need, as I've already told you, that we are giving them the GCSF, the antiemetics, so that they don't have to come back to us. There are other interventions which are targeted on reducing their problems, like bone modifying agents. Without any problem like hypercalcemia, where this is an urgent requirement, we stop all such treatments. But if a patient is symptomatic and it is required, then the patients may be admitted, or at home we are giving all such agents. The physician interaction initially was only reduced to the patients who were admitted, but now we have, then we started off with the telemedicine clinic, in which we were calling them via WhatsApp on a video call, and we were asking how they are doing. Now we have started in-person physician clinics. Initially it was one clinic per week, now it is twice a week, and we aim to increase the patient and in-person clinics as well. So not only this, all the admitted patients, they are seen by the consultants every day. We have a dedicated COVID camp where all the patients who have some symptoms, they go there and they are checked, and if it is required, their COVID PCR is done. If it comes back positive, then we have a dedicated COVID ward where the patients are kept, all such patients, and physicians see them regularly, and once they are asymptomatic, they are discharged. Other than that, we have COVID ICU where the patients are seen by our intensivists, and whatever possible is being done for them. But during the stay, when the patient is COVID positive, we hold their chemotherapy. However, if they require any scanning or if they require a radiotherapy, then these services are offered to them. And if a patient is requiring any scan or radiotherapy and that patient is COVID positive as well, they are dealt with at the end of the list, at the end of the day. And once the patient has been given radiotherapy or the scan has been done, then their complete disinfection of the machine is, and that room is done, so that the next morning a new patient who is not COVID positive can come over and have his treatment as well. So in nutshell, we are trying to do as much as is possible in a resource constrained area. We do not want to compromise on their outcome, and at the same time, we do not want them to get COVID infection from this setup because we know that they are immunocompromised, and once they get infected, then their recovery is less speedy as compared to the ones who are not COVID positive. Thank you very much. And if there's any question, I'll take it at the end of the session.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Athar Siddiqui. I'm one of the consultants in anesthetics and critical care at Shaukat Khanum Hospital, Lahore. And in the next 20 minutes, I'm going to talk about the ethical challenges which we experienced in our critical care setup during this COVID-19 pandemic. So ethics is all about principles, the equity, equality, privacy, values, and it involves the judgments about the way we ought to live our lives, including our actions, our intentions, and our habitual behavior. Now, where individuals lack decision-making capacity, especially when they are in a level 3 critical care bed, where they are put to sleep and they are put on ventilator, or the 80% of the population in the intensive care, when they are awake, they are liable to suffer from delirium. So paying attention to the values of such people who are either asleep or who are delirious regarding their privacy and their confidentiality, as well as their social and religious and cultural beliefs and values, and most importantly, the relationship between them and their family members. And the the duty of care, which as a healthcare professional we develop between ourselves and our patients. The respect for the persons who require transparency and truth-telling in the context of carrying out public health and research activities, that is a very important aspect, that how we protect their data and how we protect their information and how do we present it at the organizational and to the national and international level. Then the obligations to protect the fundamental rights of the healthcare workers and the society in general. I'll talk about it in the next few slides. This is the gist of a paper published in the Lancet exactly 30 days ago on the 1st of June, in which they highlighted that the pandemic COVID-19 brought the scarcity of much needed resources for critical care. And it also emphasized that there was a lot of need for the training and education of the healthcare workers at every level. And may it be was the most advanced countries in the world in the West, or it was the low and middle income countries like us over here in Pakistan. Then it compelled all of us for the modification of the guidance developed in high income settings to establish management approaches that match local resources and research with the focus on clinical practice in low and middle income countries so that we can adopt to those. So every time we were looking towards what's really going on in the West, so what's really happening over there, so what's the data which is available over there, apart from the data which was also anecdotal data which was also available to ourselves on the various WhatsApp group and on the various websites or on the national website developed by the Ministry of Health in Pakistan. Then this paper also highlighted the lack of targeted therapeutics, and consensus on the management led to the unmet needs of the critically ill patients, with some subgroups exposed to interventions that do harm. So that was another most important ethical issue which I would highlight in the next few slides. The most important thing about the COVID-19 ethical issues was the situational awareness vis-a-vis to our patients and to their relatives and to the healthcare workers, because this was a situation where when the patients, they were admitted in the critical care units, their relatives, they were not allowed to come and see them. Although we tried to let the patients to keep their own mobile phones and to make the video calls to their relatives, but there were so many taboos related with the intensive care unit, like whosoever goes over there on ventilator is, does not survive. There were few, very funny and sometimes very serious sort of YouTube small films circulating on the social media like Zahar Ka Tika. And then the situation of particular vulnerability, especially in case of our patients who had lower physiological reserves, who were immunocompromised, and who had more comorbidities as compared to any other person who is normally fit and healthy and catches the COVID infection in the society. So we had to adopt sometimes an exclusiveness and sometimes an inclusiveness policy for the patients, regarding that they are not singled out, that we are happy to treat them, and just we are over there to do everything for them. And at the same time, we had to look after their relatives as well. And there were a lot of communication issues which we encountered. There was no single focal person which was there in the family, and everyone in the family wanted to talk to the consultant who is looking after. In the next few slides, I'll let you know how many patients we dealt with at what time. And then the healthcare workers as well, that we really needed one focal person from the unit to talk to the one focal person to the family, and sometimes that was possible. And for the majority of the time at the start of the pandemic, it was a very haphazard situation. Then the main ethical dilemmas with which we suffered was the controversies in the management of the COVID-19 patient management. For instance, initially the evidence which was there in the literature was that we should go for the closed circuit versus the non-invasive ventilation, and we should be adopting certain procedures which create less aerosolization, and the NIV option is less acceptable in the treatment of the respiratory support to the patient. However, with the later on experience with the better PPEs and all that, we came to the conclusion that the non-invasive ventilation was the answer to the majority of our patients who came in our intensive care unit as a level 2 bed, and we averted them in going onto the ventilator, and they were stepped down to the level 1 bed. Then the other ethical dilemma was the various U-turns by the very esteemed organizations like World Health Organizations, where their Solidarity and Prosperity trial is one of the examples, where individual and combined drugs were studied in the Solidarity and Discovery projects. And one of the most important arm of their trial was the hydroxychloroquine arm, and due to the safety concerns and evidence of arrhythmias leading to the higher death rates, the WHO suspended the hydroxychloroquine arm of their Solidarity trial in May 2020 after recruiting more than 3,500 patients from 17 different countries. And then within 3 days, the questions were raised about the analysis of the data and the reviewers as well, that who reviewed that article, and then the hydroxychloroquine arm was again taken up in the Solidarity trial. The other ethical issue was about the certain treatment strategies, like the most common drug, which were the most fancy 3 interventions which were considered in the intensive care patients were the tocilizumab, the remdesivir, and the convalescent plasma. Now, one of the drugs which was selling like hotcakes, and in the black market, it was sold around more than 15 times the original price. That was not carrying the DRAP approval. So there was a letter from the government of the Punjab and the federal government that this drug is not approved as yet but everyone was after that medication, and on the WhatsApp circles, every clinician was asking for from where they can get this sort of that drug. Then the use of unproven interventions outside research. The most famous was the Sanamakhi, that this, in the level 2 patients in the high dependency units, the relatives, they were adamant that their patient should be given the Sanamakhi, and that was not a medication. And however, we were quite worried about the quality and the safety standards which govern the administration of these interventions, which were offered by their relatives to the patient. Then what rights do the patients or their authorized proxy decision makers do they have about the risks versus benefits about these alternative medical interventions? That was a question which was never addressed. Then under what circumstances might it be appropriate to override an individual's refusal or acceptance of diagnostic therapeutics or preventive measures? And so these were the situations. Then the most important aspect was that the hospital where we work has a very strong research department. Then what is the appropriate role of the research during COVID-19, which we badly needed? We were all the time looking towards the West, but epidemiologically our curves, they were different from the Western curves. So how might the circumstances surrounding pandemic affect the process of informed consent to research? That was an important aspect. what methodological designs are appropriate, and how should research be integrated. To be very honest, these were the questions which were probably faced by the Western society, and they were more pertinent to them. We were over here in our part of the world, not in our ICU, but in the majority of the country, initially we were struggling with the PPEs. So the other most important thing was rapid data sharing. So when the Italians, they did the postmortem against the advice of the WHO, and they found out that it was not an ARDS sort of picture, rather it was a diffuse alveolar disease. So everyone, pointed out the fingers towards them that this is not a peer review information. This has never been published. So basically, this is something which I digged out from the International Committee of the Medical Journal Editors, which said that every researcher who engages in generation of information related to a public health emergency or acute public health event with the potential to progress to an emergency has the fundamental moral obligation to share preliminary results once they are adequately quality controlled for release. So I think the Italians, they were absolutely right in publishing their or sharing their data. Then the other ethical issues were the rights and obligations of the frontline workers, the obligations to protect the health of the frontline workers. In our hospital, the workers who were more than 60 years of age, they were advised to work from home, and there was a lot of unspelled gender discrimination, which was tackled very well, and everyone was kept happy, and everyone rather stepped forward in their own personal capacities to come forward and work for the benefit of the patients. Then the obligations to provide material support to the frontline workers. PPEs, in our hospital, they were promptly and abruptly supplied to all of us. Obligations to the workers' family, that is a very important aspect. I'm just sitting in front of you because at the moment the gentleman who was supposed to be over here in my place talking with you at this time had 2 family members suffering from COVID, so he was relieved and I was just put in at the 11th hour to talk about these aspects. Determining whether individuals have an obligation to serve as a frontline worker, that was also there, and what special obligations do workers have in the healthcare sector. The other most important aspect from the ethical point of view was the triage of the patients. The triage who would come through the cancer hospital ICU gate. Everyone with COVID-19 requiring level 3 bed, or just the cancer patients who were registered with us having the COVID, they would be coming to us. Then what were the various guidelines which we developed with us? And in that, the most important aspect was a chronological age barrier. Was it justifiable? Which I don't think. I think the physiological age is of more important than the chronological age. Then if the cancer patients were allowed to come in only in the cancer hospital ICU, how do we prognosticate about their illness vis-a-vis to the COVID-19 infection, considering their immunosuppression and pure physiological reserves? There were very little international data about it, and we were unable to publish our data because of various logistics with which we were involved, which I will talk in the next few slides. Now, who should be ventilated? The triage decision. The Society for Critical Care Medicine guidance categorically threw out of the window the possibility of ventilating more than one patient on a ventilator because the physiology of the patients with COVID-19 ARDS is complex, and it was realized that that is not at all possible. Then the other most important aspect which we had was the burnout syndrome in our intensive care unit, because we were looking after the critically ill patients at 3 different locations. So we moved our main critical care area to one of the wards And whereas originally we had only 15 bedded ICU with 11 ventilated patients and 4 HDU patients. So we converted a whole ward into a 35 bedded ICU, and then we trained all the staff, including the medical and the nursing and the healthcare assistants and everyone. And for that we adopted an empowerment paradigm, rather a patronizing paradigm, and we spread out the medical staff into the 3 different locations, and we spread out the nursing and the ancillary staff as well. The training of all the non-critical care staff for the ICU was a big challenge, but to our surprise, our medical colleagues and our nursing colleagues, they came forward willingly, and they came forward with open arms and adapted to their new role. We had a mix and match of these staff, and yes, the critical care staff was overlooking their shoulders. Then the human and the material resource allocation for the ICU was really challenging. We grew up from 11 ventilated beds to 35 beds. We had specific resource allocation decision making, which was done at the highest level of the hospital. We had procedural considerations applied to the decisions about resource allocation as far as the expensive medications were concerned, and so on and so forth. Then we were initially waiting for the Western or the Chinese curve of the critically ill patients to be the same in our population, where their critical ill patients, they were around 10%, and 39% of pneumonia patients, they were admitted in ICU, and 10% required mechanical ventilation, and out of those 68% discharged and 15% was the death rate of the pneumonia COVID patients. So we thought initially that out of the total positive COVID patients, we will be having 5% of them in our critical care units, but it did not happen. Although in our hospital, we were adequately prepared for that. The most important aspect was about which we were all concerned from the ethical perspective was the cardiopulmonary resuscitation. How should we perform the CPR on a COVID-19 patient who is likely to generate a lot of aerosolization? So even the first responder who needs to be there on a COVID patient should wear all the personal protective equipment and with the bare minimum people around that, and the CPR and the positive pressure ventilation, the process of intubation generates aerosolization, so one should be very careful. So we had to train our whole staff and our rapid response team and our Code Blue teams to adapt to the new guidance according to the American Heart Association guidelines, and the full PPEs were to be worn by the first responder and the whole of the team. The trust upon the medical staff was another issue, which is really a very difficult aspect for me to talk about, that we were asked to record, video record, the dispensing of the expensive medicines when given administration, sometimes by the patient's relatives who were paying for their patients. And because the 75% of the patients in our hospital, they are paid by the donations, so we were asked to record that. Whereas I think as a person, for me, who was working in the COVID ICU, and I'm talking on behalf of all of my colleagues, right from the consultant level down to the ancillary worker who is working there, I think we needed to have said this to everyone: believe on us, and we will not betray you. The communication barriers were loads encountered between the patient and the ICU staff because of the personal protective equipment which we were wearing, because of the unfamiliar environment with which someone has never thought about, coming in the level 3 bed over there or level 2 bed over there in the intensive care unit, and between the relatives of the patient and the ICU staff because they were unable to see their loved ones, and between the patient and his family. And if the patient had a telephone, and he was all the time, complaining about various aspects. Even, the mattress on which he was lying was not probably the same mattress on which he normally lies down at his own place. So that may have made him, irritable, and he was complaining about that thing. So we had to deal with all these aspects. Then the stigmatization and discrimination attached with the COVID-19 infection. There was less and less social support, although generally on a societal basis, the people, they were paying less heed to the advice to the medical staff that they should adopt to the social distancing, they should wash their hands, and so on and so forth. But there was a stigma attached. Even among the most educated families, there were issues regarding the death, and if the death happens, then how the body is disposed of. And there were two different spectra which were available in our society. There were news that in some Karachi hospitals, they thrashed the medical staff because there was a little bit of delay in handing over the body for the burial. And on the other hand, our experience was that we were left with the body by the family, that we should dispose of the family as far as the burial is concerned. So we had to do the burial and those sort of things. The physical manhandling of the medical staff, I have already said a few words about it. The guidance for the managing ethical issues in infectious disease outbreaks. Luckily, this paper was published, a little handbook was published by the World Health Organization in 2016 in light of the Ebola pandemic, which was there in the African countries, and in light of the Middle Eastern virus outbreak which happened in Saudi Arabia, and before that in SARS. So this is an important document which was already there, but probably we at least at our level, who are not dealing with the infectious diseases, we never thought of going through this important piece of guidance which was already there for all of us. Thank you very much.
You're on.
You have to
Just इसको इसे फुल स्क्रीन कर दीजिएगा. Can I begin?
Yeah.
Dr. Mariam, should I start? Can you hear me?
So, Dr. Bushra, you can start now.
Thank you.
Slides को please slideshow में run कीजिएगा so we can see these as well.
It is on slideshow right now.
Can you see them? Dr. Mariam, can you see the slides and can you hear me? जवाब मिल जाएगी तो अच्छा होगा.
पीछे चलो, पीछे चलो. Start.
Okay, Assalamu alaikum. Thank you for inviting me to. Yeah.
Please,
Yes.
अपनी slides को full screen कर दें.
Full screen पे है slides. All the slides हमारे हिसाब से.
It is not. नीचे से करें यहाँ से. हाँ जी, दोबारा share
से करता हूँ.
Okay, please.
अब है?
No, your slides are not shared with us.
इसको बंद करिए.
Escape करो.
इसको बंद करके दोबारा वो करें.
Okay, we are going to screen share slides and go full screen now. Can you see them full screen now?
आपको अभी नजर आ रही.
Now F5 please.
F5 करो. Okay.
Yeah.
VR हमारी स्क्रीन में फुल ही आ रहा है.
चलें, fine.
Okay, thank you. You can hear me?
Your slides are disconnected with us.
या मैं कर रहा हूँ, दोबारा कर रहा हूँ. Now can you see them full screen?
Yes, sir.
Okay, पता नहीं क्या हुआ मगर हो गया.
Okay, thank you very much for asking me to share the experience at SIUT with our cancer patients. So today what I'm going to try talking in the next 10 minutes is not looking at the breast unit in isolation, because no unit in a hospital can work in isolation. Everyone's kind of connected. So we will start with the fact of what evidence was telling us and how we dealt with the COVID story, and then some of the ethical challenges we faced. Since we were not the first country that got the virus, so there was some kind of international guidelines that helped us, and some of our speakers have already kind of, spoken about them, that the cancer patients were divided into 3 categories, the A, B, and C. And when they were, so A was, of course, those that came under the domain of emergencies, and B was actually the category that one had to deal with and decide and prioritize and see what treatment managements could be given. The treatment managements, of course, revolved a lot around the tumor biology, which we will talk about a little later, but we had some institutional imperatives to take on when COVID came and hit the country. One of the imperatives within our institution was that we have a major bulk of patients coming who come for dialysis, and if they do not receive dialysis, I mean, it's like a death warrant for them. So it was a service that needed to continue and go on. And medical oncology kind of needed to also proceed with the business as usual. However, there was a natural attrition of patients coming in because of the lockdown, which happened quite early in the province of Sindh. However, the patients that did come and were already in the process of neoadjuvant chemotherapy, it was continued, though the spacing was increased, like from a weekly to 2 or 3 weekly doses. And this happened because of the fact of their transportation and personal factors and decreased immunity. So we had to make sure these 2 units would kind of work and move on together. But our institution, being a free hospital, has always kind of come up in front in times of crisis. So whether it was the floods or the earthquake, our institution always made a commitment to the disasters that happened. And henceforth, when this pandemic hit, it decided to show commitment towards starting a service for patients as usual, free of charge. So the first thing that the institution did was we kind of needed to sustain our healthcare personnel. So mandatory people would come to a hospital like low staff. So APs and above came. Junior staff only came when they were on calls. So we had to make sure services would continue, because at that point in the beginning, we didn't really know how the pandemic was going to hit us. And senior faculty changed their roles. They had to wear very different hats on and decide in developing different isolations, different outpatient care for testing, and dealing with patients, getting an ICU going for these COVID patients. So it was a different experience in developing and deciding lots of issues to have a systematic service, not compromising our healthcare professionals in it. The different roles and the discourses that senior management and faculty played in this, I think I would say hats off to them, because personal protective equipment, medications, looking at the psychological well-being of our healthcare staff was a major discussion during developing the system at our institute. But we had, of course, issues that were ethics related, some of which have been highlighted by different speakers, but I would like to touch upon them. As an institution, when we were talking about continuity of service for the pandemic, there was a lot of discourse and debate on what is the responsibility of the institution, because by that time, the other hospitals had kind of come into play. There was service, but service was not being given free of care. So where did our responsibility as an institute go up to? Because primarily, we are an institution that deals with transplant, dialysis, and oncological management. So a debate on the responsibility versus the need of the day was a difficult discourse to have. And after much debate, we kind of decided to continue both, which led to other factors where the numbers and the peaks coming into the country were going on, and the fear factor increased. So whether it was fear factor of your healthcare professionals or fear factor of people who were even not coming to hospital because of fear of getting the disease, this was an institutional debate that constantly went on, and how responsible could we be for drawing a balance in them. The healthcare professionals was, I think, in some way the toughest part, because Corona as a pandemic seemed abstract to a large group or the population unless it really hit them. So we had three categories of people: people who were very scared, people who I would say comparatively a balanced set, and then there was those who didn't believe in it. Now, for the ones who were very scared, to getting them to doing duties was difficult, because we do know that doing things voluntarily is the way we would like it. But if we would look at free will in isolation, then the responsibility of the institute in providing service to all comes as a major challenge. So to deal with things like this, we would have sessions with all healthcares, like so from our lower staff, the ancillary staff, to nursing, as well as the doctors. We would have combined sessions with them, maintaining the social distance and trying to put their fears at ease. It is, we did make choices regarding our healthcare professionals, those who had asthma or who had many comorbids, were kind of placed in other areas where the exposure to COVID would not be too high. However, on the medical oncological side, there was a time for a couple of weeks where between the doctors, the nursing staff, and some of quite a few of the staff in that area had acquired COVID. So the replacements that were given in those departments were not really at par in being as qualified as the general staff that is there. So the question of was it compromising care at that point, or so should you cessate it or should you continue care, knowing that the people providing the care were not at par with it. However, that was for a short duration, very worrisome, and a feeling of, if I may say, guilt by senior personnel, because you knew the juniors were not as qualified. However, at no point were they ever left alone without senior backup or support in helping them wherever they got stuck. The thing which brought us, after 2 months of being in this pandemic, was we needed to return back to clinical work, and getting back to clinical work meant that we needed to develop standard operating procedures and make sure our personnel would not get infected and protect them as much. We resumed our tumor boards quite early in the day, made sure it was less academic and only the key people from each area sat down and prioritized according to the patient and the tumor biology in which ones should go for surgery. Of course, failure for, response of chemotherapy came in as a priority. Those which some of my colleagues have just spoken about, we more or less followed the same policy, but surgery landed up kind of taking the forefront because it bought time for the oncologist at that given point in time. The interesting part that came up as a challenge was looking at the patient's perspective, and we had a variety of patients. As was mentioned, those patients who had hormone receptor positivity could, and it's even recommended to give them that and call them back in about maybe 8 to 12 weeks' time. But living with that thought of cancer is quite fearful for the patient. We did counsel them to the best, but knowing a few, they did go to other hospitals and just wanted the cancer treated, because for them, COVID was a chance that they may get. However, cancer was the disease they had. So it was an ethical challenge, because as a policy, we had stopped surgeries for a short span of time, and patients could not really relate to the fact that 8 or 12 weeks is not going to overly change their prognosis. Similarly, there was a set of patients that found it difficult to even want to come to a tertiary care setup, which would have patients who were COVID positive over there. So there was this fear of coming to the setup and being exposed to another patient that may be COVID positive. So the patient's perspective we found quite diverse, because for some the word cancer and having that treatment was a very personal experience, and they were not able to see beyond it as a pandemic. Those who had been able to find some kind of transport and come from interior of Sindh found it even more difficult because other issues of finances and places to stay were also problematic. So what I can say is, in conclusion, that I'm sure you all as an institute too one size cannot fit all institutes, and one really has to look at their infrastructure and what the main vision or statement of your institute is, and what your patient pool is that comes to you. So you have to make decisions according to that. However, I think most institutes try to make sure the ethos of the medical profession, where the provided service given to patients is maintained and is maintained at the best quality they can, keeping the patient's best interest in the forefront. Having said that, I think understanding and the responsibility of your own healthcare professionals and their mental and physical safety and security from the surrounding is something that one has to tailor make according to their environment. So I would end on that, and I would leave it open for discussion.
Thank you very much, Dr. Bushra. This was a very insightful presentation. I thank all speakers for their very detailed and thought-provoking presentations. So I think while everyone gathers their thoughts and we move on with the discussion, I'll call Dr. Amna Hassan, who is the co-convener for this session, to share her comments on our session so far, and then we can move on with our questions and answers.
So I think it's been a wonderful session in terms of bringing together and highlighting all the challenges that we're facing across the country and across the globe as we navigate this pandemic. Unfortunately, I believe ethical issues only come to light with time, and once the initial panic of things settles, that's when ethical issues are highlighted and brought forth. So I think discussions like this bring challenges better. No, I think there's one. So I think we can start with our discussion and we can go forward.
Okay, so Dr. Amit, can you hear us all well? Aap audio mein koi issues to nahi ho rahe? Okay, great. So I think all the presentations have very beautifully highlighted the fact that in a lower middle income country such as Pakistan, we already struggle with a patchy healthcare system, limited healthcare infrastructure and available resources, including human. And the COVID pandemic has actually put a huge strain on our existing healthcare infrastructure. The other issue is that because we are dealing with an evolving epidemic, the science related to this epidemic is also evolving. So what we knew about this disease and its management in March, we haven't made huge leaps of progress since then, but we do see new evidence coming up every day. And this has made the life of those involved in frontline healthcare provision very, very challenging. So my first question to Dr. Halima and Dr. Kulsoom is that you have both highlighted in your presentations that there is some international consensus on how cancer care should be provided during this epidemic. But we initially did discuss that global health has a lot to do with context. And sometimes what has been agreed via mutual consensus and international guidelines cannot be readily translated to our context. So would you like to expand a little on your experiences? And I'll ask first Dr. Halima and then Dr. Kulsoom on how you were able to negotiate the available international evidence and adapt it to our local context. You have both raised some of the points related to that in your presentations. If you could expand on that a little bit, please.
you able to hear me?
Gee, we can.
Okay, all right. For pediatric oncology, we basically prioritized through multidisciplinary meetings. So we took the international guidelines, and we had a detailed actually webinar just on pediatric oncology that discussed the guidelines in terms of where you can compromise, or where it's safest to delay chemotherapy and where there is no choice. And then we used our tumor boards or multidisciplinary team meetings for decision making on a regular basis, looking at individual patients and trying to deliver the best possible care. Obviously, like the thing, one of the things that I mentioned in my presentation, sort of the unforeseen thing was with the lockdown, patients not being able to make it. So we had things set up where we would be able to give them chemotherapy. We had the beds, but in the first 2 weeks, patients just could not make it to the hospital. And if we'd anticipated that from a social work perspective or made some kind of transport arrangement for those patients, maybe we could have tackled that better. And so that is something that was sort of, I think, unique to our country or our city or how things are done here. Second thing has been border closure with Afghanistan, because as you know, a lot of patients come from Afghanistan. So because of border closures, they have not been able to come for 3 months for their chemotherapy. Most of them, we've told them what to get locally if it's available, and at least the basic stuff they're managing there. But obviously, it's a huge deviation from what would be the standard of care. So I think really communication within the departments in the hospital and with the administration to make sure that the most important and urgent things happen, and really also with the family, letting them know where we are having to deviate from standard of care because of the situation, and making sure they're also in the know of what's going on and why decisions are being made the way they are. So I think that's kind of how we tackled it.
Thank you, Dr. Halima. So, Dr. Kulsoom, if you would like to share your perspective.
I agree with Halima, and the thing is that the cancer care guidelines have not changed because of COVID pandemic. It is how you can deliver it. I mean, the treatment of stage 1 or stage 2 breast cancer or stage 3 colon cancer remains the same. It is how you prioritize your patients. If a patient is able to come to you and he can afford and there's no transportation problem, then a patient who's already been started on some treatment, on chemotherapy or radiotherapy, you would like that patient to have it till whatever has been suggested for him or advised for him. However, if there's a patient who's unable to come, then your hands are tied up. You cannot go to a patient who is in Afghanistan and Chaman and KP. So whenever they come to you, we restate them if there is a gap of more than 6 to 8 weeks, and we see whether there's a need of some other treatment, or the treatment which was working previously is doing fine and we can restart it. It is based on individual patients' setup. However, where we can give them oral medication in the form of CDK4 inhibitors, in the form of hormonal therapy, we try to tide up a bridge of that period. And now when they have come back to us, we are again restating them, and if some other therapy, some surgery, some radiation is required, we are offering them as per the need.
Okay. Thank you so much for sharing this. I'll take this question a little forward. Because we are discussing how we have adapted international consensus guidelines around cancer care into our local context. Dr. Amir shared with us existing Pakistani guidelines about clinical decision making during COVID-19. I'll direct this question both to Dr. Amir and later to Dr. Athar. But firstly to Dr. Amir. Dr. Amir, could you because any guideline is as good as its uptake. So these guidelines are available. These were, I think, initially launched about 2 months back, if I remember correctly. Could you share, or do you have any data on what has been the uptake of these guidelines across Pakistan in various institutes? Do we have institutional guidelines based on this framework for making allocation decisions, or is the practice very variable still?
Okay, so this is actually one of the research questions that we are exploring right now as to what impact the guidelines actually had. Or are they just sitting on some various websites or in some inboxes, in various email inboxes and not doing anything? We really don't know that. What we can gauge roughly is that the number of queries that we get regarding the availability of these guidelines has been there constantly. So they've been forwarded, etc., etc. But how many times have they been actually downloaded from the NBC website or from the COVID website or from the NHS website? We really don't know. So that is one thing that actually needs to be explored. And if they were downloaded and they were looked at, did they impact upon the decision-making process of the end user? Did they help in formulating SOPs at that particular institution? That data is not available right now. It is only with time that we'll try and extract that from various institutions as to whether they actually access them, and if they did they do anything with it, or was it just archived? So important question, but I really can't have the data response for that right now.
Okay, thank you. So, so I'll take this question now to Dr. Athar, because our ICU guidelines sort of reflect what the national guidance is on this aspect. And because you already have some experience on how we made triage and allocation decisions, would you share our experience, your experience regarding this? You did mention in your presentation about communication challenges, because the real challenge is not making allocation decisions. The real challenge, in fact, another challenge is communicating those decisions to patients and families. And especially when we are operating in the context of Zahar ka tika and all that you mentioned in your presentation. So, so if you could share your experience regarding this.
As far as the guidelines were concerned, and the most important thing was that to contextualize those guidelines to our purpose. It was not only up to over here. The challenges initially were when the influx of the patients started coming in, that whether we have an intensive care bed available for those patients or not. I exactly remember that all the private hospitals in the private sectors, they were full, and on the media there were reports that all the government hospitals they are full, but the government stance was entirely different. They were portraying that so many hundred beds are still available. The communication barrier was everywhere. It was there between the people who devised the guidelines, who modified them, who tried to implement it, and then at the shop floor level, the communication barrier was there, between us and the patient's family as well. So everyone tried to resolve those issues according to their own capacity and according to their own resources, which we tried at our best level how to resolve those issues. But there were issues related to those things. There were certain basic things which were lacking. For instance, we were still struggling about an ICU registry in the country, and that was my dream, that at least I should have an ICU registry at my city level. I understand that Dr. Madiha Hashmi is working on that project in Karachi and nationwide as well. But there were certain hospitals who were, I don't want to use some negative words, but they were not included into that registry. So it would have been much more easier if the registry would have been there. And at the government level, it only required 4 clerks really to ring up every hospital and try to, put the numbers over there that we have got so many level 2 and so many level 3 beds available in such and such and such hospitals, and then we could communicate between each other if we needed to transfer one patient if we did not have the bed available to us. Dr. Ahmed, you wanted to say something?
So actually, although we are not involved in that exercise from the center's point of view, but I do believe there is some sort of an initiative by the Ministry of NHS and Khan University Hospital. The university and the NHS department ministry are conducting a survey right now, because we've actually received a survey at SIUT. So there is something of that nature going on. How much that has developed, I'm not sure, but there is some initiative. One thing that this pandemic has actually brought out is the ability to gather data, and pretty reasonable data actually has come out on various different levels. If you see the various data, so I think eventually we will have your dreams will come true.
In Karachi, there is, just to add to what you're saying, there was some services provided by the government that was informing serious patients about where beds would be available for them.
So in fact, that's the COVID website, the COVID app on all phones. I mean, if you have that application, which shows you the red spots on hospitals which are full and the green spots on hospitals which are not full. So that's available. That's actually available nationwide right now. But the ICU registry that you're talking about, the capacity of ICUs to handle and what kind of patients they can handle and what kind of equipment they have, that actually the data is being gathered right now.
That's great if that is happening.
As we discuss data, one of the things and one of the questions that will come up is the authenticity of data as well. I mean, I think it's a challenge world over, not just Pakistan, and given all the retractions that have come along. Recently, in fact, journals within Pakistan are actually sending out emails which are saying we're not going to publish on COVID because it's an evolving situation and perhaps we'll have to retract. So it was actually interesting and surprising to receive such an email that they're not accepting anymore.
So I think it's great that you have brought this up because Dr. Athar especially highlighted the issue of the challenge of dealing with upcoming evidence, especially related to therapies that are currently available for COVID patients. And because nearly all of these therapies currently are experimental in nature, again, discussing this from our context, because you need a very strong regulatory framework when you are administering experimental therapies. Therapies for which evidence is not available. So all over the world, existing treatment options for COVID are being either given under some monitored protocols or emergency use authorizations or expanded access programs. And these are the frameworks that are currently not practiced, at least in Pakistan, and they are not even defined as such. So what is the panel's comment? Does this not put us at a huge disadvantage in terms of the fact that we are using these therapies without adequate monitoring or collection of appropriate data, and we will come out of this epidemic with no conclusive answers for ourselves? So this is not really a question, but just a food for thought. And if anyone has any comments regarding this or suggestions, it would be great to hear this from the whole group.
So may I intervene? So being part of the review process for research during these COVID times at two levels, at the National Bioethics Committee level, and also at the GRAP has the Clinical Studies Committee, and I'm a member of that also. So we've seen a variety of these, exactly what you're saying, something like a Me Too researcher. So it's COVID times, there is hot topic, the grants are available to HEC also and other places also, and everybody wants to jump in with their mostly half-baked proposals, which are then thrown into the field, and they come to us for review, and we spend hours and hours reviewing them and trying to make sense out of them. the data, so even when they are actually done, so there is a trial of some sort of 30 people or 20 people or 15 people, the data that is coming out will probably end up in a publication possibly somewhere, but it will really not add to the body of scientific knowledge coming from Pakistan, because there is no, we see very little consolidated effort. You've got the solidarity trial, but how many institutions in Pakistan are actually in that trial? But that's one. So we don't see much of collaboration within Pakistani institutions trying to do some randomized control trials or some sort of a trial in which some solid data is able to be generated. So that's, I think, a major shortcoming.
Okay, from a clinical perspective and looking at these are unprecedented times, right? So research is not really, I think, happening the ideal way it should, and one can constantly critique it. But when we talk about what is going to come out of this pandemic, I believe as a clinician, it is going to be more a retrospective analysis at one point, which is going to really come up with minimal protocols or standards of care. And if institutes are following a discussion or a committee that is managing these patients in continuity, I think that is the way I see it move forward. That is something which this morning only I was talking to infectious diseases, and at our institutes, their team, our intensivist team, they're sitting down for the last 3 months and coming up with their protocols in which they're managing patients over here. And they are at one level starting to come at a comfort of managing these patients. Yes, there is a small subgroup that they are again up in the air with how to manage them. But I think the retrospective analysis will give us the real answer at the end of the day.
But Bushra, that is the weakest possible data available. That, and this was an opportunity. If the scientific minds, there are scientific minds in Pakistan, if they had gotten together to make something more consolidated, and this pandemic, unlike Ebola, etc., has actually been a long drawn one, and it's not ending. So there's still time for a multi-center randomized control trial with some variables that you can think of, or joining something else.
That Dr. Bushra has actually highlighted a very important point, and everyone is really eager to add to it. And I'll start with my bit first, taking the advantage of having control over mouse and mic currently. So I think the point that Dr. Bushra raises is very important, because a clinician's reflex is to treat. And in a pandemic, they want to do something. The reflex is not to learn. The reflex is to do something. But what a pandemic requires from us is to have procedures in place that enable us to learn while doing. So the enterprise of research is usually bureaucratic and requires a lot of pauses and reflections. And this is something that a clinician does not want to do in a public health emergency. So what is needed is robust but rapid mechanisms of research development, approvals, and deployment. That deployment should be done in a way that research conduct becomes part of the clinical process. Excellent. Rather than something Excellent. That you have to do as an add-on activity, because who has time to do this in a public health emergency? And I think this is a very important point, and one of the core reasons why we have not been able to step up our research game. And the rest of the world took this point better than us, and even though their quality is also something that we have seen judging from the NEGM and Lancet retractions, but at least they have their systems in a better place. And Dr. Athar wants to add to it also.
I just wanted to add two sentences to it. You have beautifully, put forwarded the most important perspective. I think as you said, that as a clinician, we are only eager to perform, but I would beg to differ with you over there that we are actually learning as well. When we are doing some sort of intervention, we are getting the results as well. So as a good observer, we are reflecting upon on our actions as well, that what we have done, what's the outcome, what we are getting. What I think where we should come together with our research team is that instead of going into the very delicate intricacies of conducting an RCT or those sort of complicated things, if we just simply do a cross-sectional observational studies on whatsoever we are doing in our own setup, and that will give us a very good data that what we are doing and what's the outcome, and then based on that we can reflect upon that what was our interventions and how did we do so far.
So just one comment. I mean, I agree with you, but the thing is, if you are doing a cross-sectional study and you want to see what is the outcome of your efforts or your intervention, the thing is that data would be very skewed in our setting because of the heavily pre-treated patients. I mean, they are using Senamaki, they are already had the dexamethasone, they've already had the chloroquines. So you don't know, I mean, they are not the naive patients, you are doing some intervention and recording the results. I don't know where will we stand. Our retrospective data will also be very skewed, and I am afraid that it won't be that meaningful either.
I think we have to thank WhatsApp for all of this and for this whole influx of misinformation which is available to general public.
Pandemic of misinformation.
It's physicians who are actually sitting on
They
social media and actually giving out doses and recent steroid doses is just
So clearly we all feel very strongly about it, which brings me to the next question. And this is probably the final two thoughts that have emerged from the presentations as well. The issue of moral distress that clinicians have been facing in these times. And it ranges from just like, minor levels of stress to complete burnout. Because, physicians typically are considered bad at asking for help or admitting that they are unwell, even physically. So their mental health is certainly something that they mostly don't prioritize. But this pandemic has certainly brought out the fact that all these allocation and prioritization decisions are producing a huge moral distress on everyone who's making them. So if I could get brief comments from Dr. Bushra, Dr. Mikkelsoon, Dr. Halima, and Dr. Athar on what has been your experience, not just for yourselves, but also for those who have been working with you. How challenging has this been for us, in terms of being responsible for changing lives through our decisions?
Thanks, Mariam, for that, because I think you're addressing a very important part that really doesn't get discussed in a clinician's life on a daily basis. You're just expected to stand high and strong, and your feelings are something that are expected to be closeted and left at home. However, in the team, this I would say an element of stress, but more the stress is going towards depression because of the constant fear of the unknown, the constant fear of being put into areas of duty where the fear of taking the disease home where you have old parents, the fear of your children not being able to, have contact with them, especially when you're exposed to high exposure areas. So I think it's playing a toll on the mind of the healthcare personnel at all levels. And the younger doctors are having difficulty in being able to try and switch off. So one at the institutional setup does try to, create activities that can switch. They can kind of isolate themselves from the pandemic and constant conversation, but it is having its toll on their mental health. I can say that for sure.
Thank you, Dr. Bushra. Dr. Halima, would you like to add something? Because managing children is often, very.
Yes. I think it's definitely challenging. I think obviously personally for me as well as people around me, nursing staff, the HCAs, junior doctors, it's extremely stressful. And I do want to point out some of the things that our institution has done to try and combat that. We had regular sessions available with psychologists actually out in the football field initially to maintain social distancing, where people had the option of going and talking to someone. So I think this was, I would say, at an institutional level, actually recognized earlier on, and addressed, or at least the option was given for people to seek help. Unfortunately, I think we're just not used to getting help or asking for help when we need it, especially for stress and mental health related issues. But I think our institution at least did offer that right up front. The specific things I think for women is, especially women that were pregnant. Initially, they were sent home and then asked to come back in once the data came out that there wasn't an additional risk to pregnant patients. But I think, a lot of them have a lot of stress in terms of nobody really knows the effects of COVID on the fetus or the outcomes. So even though the hospital policy now is that they can be back at work, I know all of my colleagues that have that issue are very, very stressed about that. Again, you pointed out the elderly parents and the children that you put at risk for. So that's also an issue. I think what's helpful a lot of times is support groups, whether it's online or being able to talk to each other about what you're feeling. And, that again has been limited by the fact that we're not meeting as much. But we try to meet at least once a week, address issues for our staff, and try to, sort of, you can say vent or talk about what's going on. And in a way, like the MDTs that I talked about earlier also help with that, because when you're making these tough decisions about who to give chemotherapy to, who to prioritize for surgery, when you have the support of 3 or 4 colleagues that agree with you and everyone's on board with it, I think it takes the stress away from the individual patient. So I think establishing tumor boards and MDTs, even if it is on Zoom or whatever medium you're using, I think is very important in terms of sharing the burden of those decisions. I think those are some of my thoughts.
Thank you. These are great points. Dr. Atar, would you add something?
I think this pandemic has given us a very different perspective about ourselves and vis-a-vis to our colleagues around us. I think that has given us a new insight into the working environment in which we work, where we have to look after each other from the psychological point of view as well. I think this pandemic has a very deep psychosocial element which are still emerging, not only in our working environment, rather in our domestic and in our social setup as well. So I think social support is also something. Sometimes there are so many people around you who are they may be around you as your resident who are just overworked by working into the COVID camp, like in our hospital, and they just needed a shoulder on which they can rest their head, and they can just bring out what all burden they had in their minds and concerns about their level of work or their apprehensions about themselves or to the people around them. So I think that is very important, and seeking an open psychological help or psychiatric help is still, comes with a bit of stigma or with a bit of taboo attached to it. So I think we morally are bound that we should look after each other, and in an unspelled and in an unuttered manner, we should try to help each other in that aspect.
Yeah, I totally agree that we are all very stressed, and as clinicians that we have a highest level of stress, but there are a few good things as well, which now we've learned that much of socializing is not that important. Going out and eating out every night or maybe every weekend is not that important. I'm happy that when I go back home, my children, they've fed up on their devices, and they really come and sit next to me, and they want me to talk to them, and I really enjoy listening to them. So these are the things. Our family life has a little improved, I would say. But yes, we have stresses, and we vent it out, and we have a good colleagues, good support. So this is how it works, and we don't know how long will it take.
So thank you very much. This has been, I think, a very productive session. And I think the discussion in the end has really brought together all the challenges, some of the challenges that we all face, both in the hospital and in our life in general. I think we need more discussions and sessions like this. Unfortunately, due to time limitation, we will have to close the session. I do thank you very much for spending time and sharing your knowledge with us, Dr. Arnes, Dr. Bushra, Dr. Halima, Dr. Athar, Dr. Mukulsum, and Mariam. Thank you so much for organizing this and putting it together amazingly. Thank you very much.
Thank you very much, everyone.
Thank you, everyone.
Thank you.
Thank you. Thank you.
All right. Thank you, everyone. Bye.